So welcome to tonight's webinar, which focuses on the new Aortic Disease Management Guidelines that were published last month by the American College of Cardiology and the American Heart Association. The actual guidelines are a huge document. Maybe you've seen it online. What we're doing tonight is providing you with the highlights that are specific to Marfan, Loeys-Dietz, and VEDS. As you'll hear tonight, our speakers are not only champions for our community, but they were also all on the writing committee, so they have great insights for us. A few housekeeping details before we get going. If you have any questions, please put them in the Q&A box. Please try to keep them short and general rather than more about your personal situation. We're going to leave time at the end to answer the questions. And if they're not answered, you can submit them to our help center, and Jan Lynch, our nurse, will get you the answers. And we'll post that link in the chat box later, and we'll also have it up on the screen. So now, to get us going, I'd like to introduce Michael Weimer, our president and CEO, who has some brief comments, and he will introduce the speakers.
Thank you very much, Eileen. Eileen's reminded me several times, brief comments, so I will stay with that model. You know, I was thinking a little bit about the holidays, and I have a wonderful gift idea. If somebody's looking for something special from someone special, why not ask for a trip to Chicago for our conference this summer? What a great holiday gift that would be. Anyhow, put a hold on the dates of July 13 to 16, and we'll have more details about our return to Chicago in the next weeks ahead. I also have the pleasure tonight of introducing our speakers. They're Dr. Alan Braverman, Dr. Abe DeAnda, and Maya Brown-Zimmerman. As Eileen mentioned, all were on the writing committee for the guidelines. So they not only have the expertise, but they also have the insight into the changes as well as the recommendations. And that's been, I guess the span of these guidelines have been, over 10 years now. So it's great to have three, not only participants, but, people that were active in the actual writing of the new guidelines. A little background, Dr. Braverman is an adult cardiologist, an alumni endowed professor in cardiovascular diseases at WashU in St. Louis, part of the School of Medicine. He's a longtime member of the Foundation's Professional Advisory Board and also a member of our board of directors. Dr. Abe DeAnda is a professor and chief of cardiovascular and thoracic surgery at UTMB in Galveston, Texas. We've gotten to know, we've known Abe a long time, actually. Abe was in New York City for a while, and he's been a great supporter of the foundation and also has been wonderful with members of our community. So Abe, nice to see you again this evening. Then probably one of the real celebrities, Maya Brown-Zimmerman, is an advisor to our professional advisory board. She's an advisor to our board. She's arguably the #1 patient advocate for Marfan and related conditions. One might even suggest worldwide or globally. And it's great to have her with us tonight. And she's in the process of pursuing a career in genetic counseling. So with that brief background, I'll pass it over to Alan Braverman to begin our presentation. Alan?
Thank you, Michael. And on behalf of Abe and Maya, thanks to everybody who is watching this live, and for all of you who are going to watch it at another time. Can we have the first slide? This is the front page of the document that Maya and Abe and I are going to review some of the information on updates in genetic aortic disease. It's evaluation management, medical therapy, surgical guidelines, pregnancy management, shared decision making, and really it's a whole new document, totally rewritten from 2010. And I just want to highlight in the red and blue arrows on the writing committee members. The leads on this were Eric Isselbacher from Mass General, Rania Provencia from Houston, and Jim Black from Johns Hopkins. And the worker bees were all the rest of us who did the writing and communicating back and forth. And I highlight how many people that were on the writing committee are intimately involved and have dedicated their volunteering and their time to the Marfan Foundation and other foundations that serve our communities. So that made us very proud to have so many people involved, and many of the members are listed here, some on the board, some like Abe and others, Jim Black are advisors and just vital members of our professional community. Next slide. We're going to talk tonight about the aorta and its branches and the management. So I thought we'd just start with just an anatomy lesson, so everybody's together on this. So you can see the body over there on the top left of your screen, and then the red tube shaped like a cane. Of course, everybody in this audience knows the aorta and the anatomy probably better than most. And so we're going to talk about different anatomical parts of the aorta. So as a refresher, the heart is kind of shaded away, but the aorta arises from the heart. It's the largest blood vessel of the body, about the size of a garden hose in a young adult, and then a little bit larger in older adults. And the root is the beginning part of the aorta, encompassing the valve and the coronary arteries, and then it ascends up to the level of the vessels that supply the arteries to the head and the neck, and that's the ascending aorta. And then the arch, or where those hatched lines are, that defined by the ascending aorta, and the descending aorta in between is the arch, where the head vessels come off. And then the descending aorta, where the aorta descends in front of the spine all the way down the back to the level of the diaphragm to enter the abdomen. That's the descending aorta. We're not going to spend much time on the abdominal aorta, but it's a vital part of the anatomy, especially in aortic dissection, because all those tubes can have lack of blood flow or malperfusion, meaning not enough blood flow to vital organs, which can be very serious, that Dr. DeAnda is going to talk about in some of the strategies now employed for managing acute aortic dissection. So this is the aorta. We call it the tube of life, and it's a very, very vital structure for all of us. Next slide. One of the most important parts of the guidelines is really a whole section on emphasizing how to measure the aorta. Everyone who sees individuals and talks to patients and families about the aorta really relies on very accurate, standardized measurements and recordings of what does the aortic size really measure. And so we use echocardiograms up in panel A at the top. And then we use cross-sectional imaging like CT scans and MRI scans with contrast called angiographies, MR and CT angiography. And the guidelines, again, it's not new, but I think a big emphasis on how to measure this in a standardized manner. So we all do it the same way and make the recordings in a similar manner and then report those recordings so it can be uniform and very helpful to you and to us when we say whether the aorta has changed based upon this measurement versus that measurement. And then standardizing how CTs and MRIs should be done and recorded. As you can see in that panel C, the shape of the aorta on that two-dimensional picture is of curve. It's a very dramatic curve to it. It's not a straight line. So all those diameters are measured perpendicular to the long axis of blood flow. You can see, just like if you wanted to slice a banana, you could slice it in all sorts of different manners to make different shapes. But if you want to get a round slice, you have to slice it just perpendicular to the way the blood flows or the way the banana curves. So teaching about that, educating about that, trying to get the aortic diameters constant so there won't be mismeasurements is an important part of the standardization that's in this document. Next slide. Maya Brown-Zimmerman is going to talk to us about one of the most important aspects of the guidelines, the concept of shared decision making.
So I'm really glad that this was included in the paper. Shared decision making is basically working with your medical provider to make decisions together about your care. Some aspects that they discussed in the paper are working together to determine the appropriate thresholds for surgical intervention. And the doctors will be talking about what those recommendations are as we get through the presentation. Deciding on the type of surgical repair, including choosing between open surgical versus endovascular approaches, medical management and surveillance, and then making pregnancy decisions, including type of delivery and the threshold for prophylactic surgery. This is where how you live your life and your concerns need to come into play in addition to the recommendations from the paper. Next slide, please. So how do you go about making these decisions together? I would recommend coming prepared to your appointment with any questions that you have and writing those down so that you don't forget. You can bring a copy of the relevant guidelines. These are online. I believe they're on the Marfan Foundation website, so you can print off the sheets to discuss with your physician. And then other information from marfan.org. They've got great PDFs on a variety of different areas of Marfan and related disorder care. You want to be prepared to listen to your doctor's rationale as well, so that you can have a true discussion. And don't be afraid to ask for a second opinion. And if you need help looking for somewhere for a second opinion, you can always reach out to the Marfan Foundation Help Center and they can help you with that. Next slide.
I think go back 2 slides for just a second, because I want to talk with Abe and Maya about this point. So this is not a new concept, but I think what's so important about the document is how all these various numbers and sizes and things that we talk about, that Dr. DeAnda is going to talk about, that we'll talk about when we think about surgical thresholds and things like that, we really come back to the person we're seeing because everybody's different. The same size is not the same for every person. Some person's risk of surgery is much higher than the next person. So these numbers are really what they are. They're very important guidelines, and we go into these decisions in a shared manner, thinking about the person we're seeing, what their circumstance is, how quickly it got to that point, what the family history is, what the gene is, and then trying to decide for that individual, is it better or lower risk to continue to observe, or is it lower risk to take the chances for surgery, whatever that risk might be, depending on the individual. Dr. DeAnda?
Sorry, I was muted there. You think I would have learned by now how to do this, but Dr. Braverman, you've hit the nail on the head. No longer can we really talk about aortic surgery and approaches to patients with aortic disease as one size fits all. And so the shared decision making is not just the doctor sitting there and talking with the patient, but it's also the patient talking back to the doctor and expressing their concerns. This is nicely laid out in this slide about some of the considerations. For instance, in the very last point, pregnancy decisions. And later on, we're going to talk a little bit about this concept of a center of excellence. And this is also going to come into play because some of the options that are going to be available surgically and medically are going to be dependent on the experience and expertise of the team that's going to be taking care of you. So all of this, I think everyone has been doing this in some sense at different centers around the country and around the world. But I think we set it down on paper. We just said, this is some of the considerations that you have to be thinking about. And by putting it down on paper, I think we've given patients and their families the opportunity to understand what some of these considerations are. I hand it back to you, Alan, if you want to expand on that a little bit more. You see these patients as well, obviously.
Thanks, Abe. Well, I think we'll come back to these gray areas where there had been hard cut points throughout the whole discussion tonight. So Eileen, if you can push us forward to the couple slides forward. Okay, so what we're going to do over the next half hour or so is we're going to review some of the topics that are encompassed in the new guidelines based on genetic aortic disease, aortic aneurysms involving the thoracic aorta, and surgery for aortic dissection and other thoracic aortic problems. A strong part of this guideline emphasizes the recognition that thoracic aortic disease is a genetic disease. In an individual that we call sporadic, meaning no one else in the family is known to have aortic disease, the person does not look syndromic, but they just look like anybody else, so to speak, but have a thoracic aortic aneurysm or an aortic dissection. What's been recognized is in that person, there's about a 1 in 5 chance that another family member will also have thoracic aortic disease. So the guidelines emphasize how to think about that. Risk factors for TAD or thoracic aortic disease. So we educate the professional to look for features of Marfan syndrome or Loeys-Dietz syndrome and vascular Ehlers-Danlos syndrome in the person that you're seeing. Ask a careful family history in multiple generations. Does someone have thoracic disease or an aneurysm of the head or neck or periphery? Or does somebody else have thoracic disease at a young age? And in those groups of people, the likelihood of finding a genetic variant is higher. So genetic testing should be performed. And if a positive variant is present, so if you find the gene, then you can test other relatives that could be at risk for the same condition. And the relatives tested who have the same gene can then be imaged to see, do they have abnormalities and counseled appropriately. And then that goes on in subsequent generations and subsequent family members. That's called cascade testing. So at the very top is the emphasis on recognizing the conditions at risk for genetic disease, doing genetic testing. Importantly, only a small number of people who have families with aneurysm disease, about 25%, will be found to have a gene. So also in the guidelines, emphasizing when aneurysm disease runs in a family, but genetic testing is not informative, in other words, no gene is found, we still image other family members for thoracic disease, because again, you can find other family members with the same aneurysm disease. So there's a lot of emphasis on that, good discussion, and very clear guidelines with tables like this to help inform screening family members. And this is done in a way to help really to help with doing the right thing and hopefully help with insurance coverage for this sort of testing in people at risk. Next slide. The recommendations are written like this, so I won't go over every single one, but it emphasizes again, in a patient who has thoracic aortic disease or have experienced an aortic dissection, perform a careful family history, asking about features of aneurysm disease in other family members. And that would highlight the concern for a genetic aortic condition. And in those who have aneurysm disease or aortic dissection, who have risk factors for a heritable condition, do the genetic testing with a panel of genes. So these are class 1 indications, recommendations, meaning that physicians should do these things. So those are an important part of the guidelines. Next slide. Other guidelines regarding genetic, go back one. Yeah, guidelines again, in people who have a gene, it's important to get proper genetic counseling. So you have to meet with somebody who has knowledge, whether it be a genetic counselor, a geneticist, a cardiologist, a surgeon who has the expertise to be able to understand what the gene means and how that impacts the person's care. So, and then use the genetic information to inform the specific management. And as we'll talk later, different genes behave differently with regard to their thoracic aortic care and surgical thresholds. So there's really an emphasis on precision medicine and precision surgery based upon what condition is present and which gene is involved. Next slide. Again, emphasizing widespread screening in those at risk. So these emphasize the different types of scenarios we can come up with. So the first one would be a family with aortic disease. So we know it runs in a family. A parent might have it, a child, a sibling. So it's running in the family, but genetic testing is normal. So we didn't find a gene, and that's a common scenario. But still, image the aorta in relatives in that family who are connected to somebody else. That's cascade testing to see if the other people also have aortic disease. Second would be sorry, go back one. Next one would be in individuals who have aortic disease, but no family history, still screen relatives. Again, 20% chance of finding another individual with aortic disease. And then finally, and very important, in people who've experienced aortic dissection, a tear in the wall of the aorta, very important and potentially fatal condition that can affect the thoracic aorta. Physicians and surgeons should list the size of the aorta at the time of dissection. That's very important. So this is a guideline now. So doctors like Dr. DeAnda, people like myself, would try to look for this in charts, would record it in our own records to say so-and-so had an aortic dissection and the aorta was 5 centimeters. That's very helpful when we think about how do we manage other family members when we don't know a gene that's involved who are approaching that sort of a size. So this sort of information in a family can be helpful in guiding how we might manage other family members when we don't have a specific genetic marker. So that was codified and put into the guidelines and very important new addition to the guidelines. Next line. Next slide. Dr. DeAnda is going to talk about some of the surgical thresholds.
Some of this has changed over time, and some of it was in the previous 2010 guidelines. Some of this will everyone's always worried or concerned about what is the size that you want to intervene on, and so these are all class 1 recommendations, and I'll go to the second one there, and this is for asymptomatic patients. And as you probably are aware, a lot of aneurysms are picked up with either screening or incidentally. Someone gets an X-ray or they get a CT scan for some other reasons, and now they've noted to have an aneurysm. We haven't talked about this yet, but we haven't talked about this other than the guidelines that were mentioned already about how to measure aortas, but we also talked at length about what do you call something? When do you really call it an aneurysm? But and we've laid that out a little bit. So in asymptomatic patients, someone who is has an incidental finding of a large aorta, and there's no family history, there's no identified genetic cause, and if there is a family history, but a non-syndromic history, but you don't know the size, we recommend that the aorta be prophylactically addressed when it reaches 5 centimeters or greater. In those patients who who have the non-syndromic family history of thoracic aortic disease, and once again with no genetic cause, but they have high risk features for adverse aortic events. And this goes back to a little bit what Dr. Braverman was saying, for instance, where maybe another family member ruptured or dissected at a lower diameter, or maybe there was someone who had a sudden death at a lower diameter. They can be addressed when it reaches 4.5 centimeters. Or if someone is undergoing some other procedure, for instance, they're having a CABG or a closure of an ASD or a valve replacement, they have some other reason why they're there, then it is reasonable to address this aorta when it reaches 4.5 or greater in size, in centimeters in size. The caveat is listed, and this is going to be seen on a lot of the recommendations throughout the document. The caveat, that last phrase that's added, which says, when performed by experienced surgeons in multidisciplinary aortic teams. And this is not meant to, try to limit this operation only to certain centers. But what it's saying is that if you are going to address an aorta at a smaller size, you really need to have had a lot of experience, both in doing the procedure, but also in understanding the disease process and understanding because you understand the disease, understanding what the particular risks are to the patients undergoing that procedure. So these are our two magic numbers, if you will, for patients with heritable thoracic aortic disease, 5 centimeters or greater. If there's no information, 4.5 centimeters or greater, if that patient has some high-risk features for adverse events, and that would include aortic dissection, or if they're undergoing some other type of procedure. Next slide.
Thank you, Abe. I want to emphasize one thing that Dr. DeAnda said that's really critical. Multidisciplinary team is important in the shared decision-making aspect, as the vast majority of cardiac surgeons in our country perform less than or equal to 2 aortic root surgeries in a year. I mean, it's not a common surgery for the vast number of cardiac surgeons. So having complex aortic surgery, especially when very low risk is necessary, it's important to see a surgeon with experience. Okay, what's new in Marfan syndrome? Well, moving on to medical therapy, those on the webinar tonight with Marfan syndrome are probably well aware of this, but there, over the last dozen years or so, have been multiple randomized controlled trials comparing a beta blocker to lessen the force that the aorta contracts into, the heart contracts into the aorta, or an angiotensin receptor blocker, medicines like losartan or irbesartan in the sartan family that might block TGF-beta signaling. Either one in maximally tolerated doses. I think that's a very important phrase. You know, to give the highest dose tolerated is recommended. Either one to reduce the rate of aortic dilation. And that's because in these trials, they were similar to each other. There wasn't one that was superior to the other. And then a class 2A indication, meaning is reasonable to give both drugs, both a beta blocker and an angiotensin receptor blocker. Same thing in maximally tolerated doses. And this is based upon some of the randomized trials, and then a meta-analysis, which is an analysis of all the trials looking at individual data sets that showed a potential benefit for using both drugs compared to one or the other. So that's our new guidelines for all of us. Use one or the other in highest doses, and consider the use of both for those who can tolerate both medications. Next slide. Dr. DeAnda is going to walk us through surgical thresholds in Marfan syndrome aortic root enlargement.
This is specific for Marfan now, and for patients with Marfan syndrome, it is a class 1 recommendation to address the aortic root when it's 5 centimeters or greater, with replacement of the root and the ascending aorta. Dr. Braverman had shown the diagram of what constitutes the root. Sometimes the nomenclature gets a little confusing when people say root when they mean the ascending and vice versa. So this is for the root, greater than 5 centimeters. When the aortic root is 5 centimeters, in a Marfan patient, the aortic root is greater than 4.5 centimeters, and there are features associated with an increased risk of aortic dissection, then it's reasonable to address that root at 4.5 centimeters. Once again, with that caveat that we use so often, which is when performed by experienced surgeons. As Dr. Braverman mentioned, in this country, the number of aortic roots that the typical aortic surgeon performs is less than 5, closer to 2. So if someone is going to be intervening electively at a root that's at 4.5 centimeters, it probably should be somebody who has some experience. This is a 2A recommendation. And finally, the last recommendation, and this is new as part of the guidelines, and that's the new approach to or consideration for size and getting away from the one size fits all. And that's when you index your diameter, in this case, the maximal cross-sectional aortic area, to the height of the patient. And that ratio is then calculated. And if that ratio is greater than 10, it is reasonable to replace that root electively. These calculations are easily done in the clinic, and beforehand, they do require cross-sectional imaging like a CT scan or MRI to get this information. Next slide.
This slide just emphasizes a little bit of difference in management in Loeys-Dietz syndrome. So in Loeys-Dietz syndrome, imaging, because aneurysm disease is more widespread than in Marfan syndrome, that baseline MR or CT angiography from the head to the pelvis is recommended. It's opposed to in Marfan, where the thoracic aorta is really the first evaluation segment. But in Loeys-Dietz, we look widely from head to pelvis at the entire aorta and the branches for aneurysm, asymptomatic dissection, and tortuous arteries, because that can also impact risk thresholds. And if an aortic segment or an arterial segment is abnormal, then annual or more frequent, depending upon the size, imaging of that segment is recommended. But if it's normal, imaging at every 2 years is reasonable in Loeys-Dietz syndrome. And this is, again, part of the shared decision-making. How frequently is it necessary when the blood vessels look normal? And this is also important in vascular Ehlers-Danlos syndrome. With cerebral imaging, even less frequent because of the rate of growth in that arterial segment. And then like Marfan syndrome, but without randomized clinical data, in Loeys-Dietz syndrome, treatment with beta blocker or an ARB like losartan or both drugs in maximally tolerated doses is reasonable. Next slide. I'm going to just set this up and then have Abe comment. What's new in Loeys-Dietz syndrome compared to 2010 is a recognition now that there are multiple genes that can lead to features that we recognize in Loeys-Dietz syndrome. And so the decision about aortic surgery, and I think this condition and vascular Ehlers-Danlos condition in particular involves a very complex shared decision-making that incorporates so many factors that might influence the individual risk. And again, it comes down to the risk of observation versus the risk of surgical therapy. And so in Loeys-Dietz syndrome, where there's aortic enlargement or dilation, the surgical threshold for replacing the aortic root in the ascending aorta should be informed by the specific genetic variant. In other words, which gene is involved. And even more importantly, different genes can have different variants with different effect. What's the aortic diameter? What's the growth rate of the aorta? What's the phenotype? In other words, are there severe craniofacial features and arterial tortuosity and bifid uvula and other features which predict risk? What happens in the family? What's the person's age? What's the sex? And what's the physician and the patient preference? So all these factors go into play when deciding about surgical thresholds. Next slide. And this is one table that just emphasizes the 5 different genes recognized that can lead to features of Loeys-Dietz syndrome: TGFBR1, 2, TGFB2, TGFB3, and SMAD3. And again, the levels of recommendation, meaning it's recommended, might be considered, is reasonable. In other words, the different ways we think about this depend upon the gene, the presence or absence of features which place someone at high risk or don't put someone at high risk for aortic dissection, and what diameter is present. And you can see the ranges from 4 centimeters to 5 centimeters, but in the more common TGFBR1 and 2, or the first Loeys-Dietz that were recognized, 4 to 4.5 centimeters again. And surgery still can be recommended on the smaller range of this scale when there are high-risk features or rapid aortic growth. So I think nowhere is it more clear that these hard surgical cut points have gray edges than in Loeys-Dietz syndrome. And then some of the high-risk features are listed here. Dr. DeAnda?
Yeah, this in the previous slide with the actual recommendation, if you parse that recommendation, it's important to, it tells you once again the importance of that multidisciplinary team and the center of excellence. there is so many factors that are going into that decision making, and it can't be a decision to operate based solely on the diameter. That should not be the case. There's going to the team has to take into consider a lot of these other factors, so that the risk benefit ratio of the operation versus medical management is at least given some very serious consideration before proceeding. So I think these last two slides really emphasize the need for that type of expertise in dealing with this disease.
So this, one example would be, an individual, a young woman with a TGFBR2 type of Loeys-Dietz, who has very tortuous arteries and a cleft palate and bifid uvula, and has a family history of dissection at a small size and a young age, whose aorta is 4.1 centimeters. And that person may be counseled and may accept surgery at that size. And another person with a TGFBR1 male who's 60, who has a benign family history with enlarged aortas but no dissections, and has made it to 60 and has a 4.1 centimeter aorta, and that person and the surgeon would choose, let's watch a little longer because of the natural history in that individual. Understanding that we don't have a crystal ball for every individual, and it's shared decision making in these instances.
Yeah, and I would once again, just for the patients and the families that are on this call, if the decision is not to operate, even though it says on this little chart that it's reasonable to operate at, for instance, at 4.5 or 4, that's a discussion that should be had, but it shouldn't be considered that maybe you're not getting optimal care. You may in fact be getting really optimal care if that decision has been made not to operate, but it is important to have everyone have that open discussion and understand why that decision was made.
Next slide. Okay, moving on to vascular Ehlers-Danlos syndrome in VEDS. Imaging the aorta and the branches is very important because it may identify arterial segments at risk that are asymptomatic, but the frequency and type of screening surveillance is uncertain. In general, in the individual who's asymptomatic with vascular Ehlers-Danlos syndrome, protocols typically involve MR or CT angiography from the head to the pelvis to evaluate the entire aorta and the branches, even without any symptoms. And like Loeys-Dietz syndrome, in any abnormal segments, and similar to Marfan syndrome, if the segment is abnormal, in other words, there's an aneurysm or a dissection, imaging frequently at that segment over time is necessary. But if the arteries look normal, probably imaging every 2 years, as long as remaining asymptomatic is reasonable. One thing we didn't mention is in the guidelines, because young people who have a heritable thoracic condition will be imaged over their lifetime, there's a strong emphasis on doing MR angiography over CT angiography for those who can tolerate the claustrophobia and the time and things like that, who don't have any contraindications to do an MR study. For surveillance is appropriate and preferred. So one lessens exposure to ionizing radiation over time. And again, current types of CT scans use very low doses of radiation now. So we certainly use those appropriately, but in individuals who can have MR, we prefer that for routine surveillance over time when the information can be obtained just as accurately. Next slide. Dr. DeAnda, would you comment about, go back one, Eileen,
Back one.
about the surgery in vascular Ehlers-Danlos syndrome?
Yeah, so in vascular Ehlers-Danlos, in VEDS, there is a lot of risk involved in not doing anything, and there's a lot of risk in repairing these vessels. This is something that a lot of surgeons don't like to do. The tissue itself is very fragile. It's very it's like wet toilet paper, And so there are issues with bleeding complications and later on down the road, the formation of pseudoaneurysms and other issues associated with the procedure. But that doesn't mean that these shouldn't be addressed. As noted in the guidelines, rapid arterial aneurysmal growth, and we listed it as greater than 3 millimeters per year is considered rapid growth. And that would be an indication for intervention. But once again, this will require a multidisciplinary aortic team, including in our institution, that includes a vascular surgeon, and we have recently included a pathologist who has an interest in this disease, because they can help us understand a little bit more about what some of the risks are and can be. But there are these are not easy operations, and they should be done by performed by someone who's done more than one of these. Next slide.
Okay, moving on to pregnancy. As Maya commented earlier, the emphasis on shared decision-making and the importance of counseling, genetic counseling, maternal fetal medicine specialists and high-risk obstetrics, cardiologists, cardiac surgeons, vascular surgeons, as an entire team when approaching pregnancy with the mother and father who are going to be expecting this child. So in people with genetic aortopathies who are contemplating pregnancy, so emphasis on before pregnancy commences, genetic counseling to talk about what heritable condition is present and what that would look like for the mother and what that would look like for the child and how that would affect the family is recommended. In aortic imaging, again, depending upon the condition, how widespread, but could be head to pelvis, or it could be thoracic, or it could be an echocardiogram before pregnancy to determine what does the aorta look like, and that can help inform what the risks of pregnancy would be, and specifically what the risks of aortic dissection related to pregnancy. Next slide. For those with thoracic aneurysm or those who have risk of aortic dissection, it's recommended that pregnancy be managed again by a multidisciplinary team. And we talked about all the members who are involved in that team. Now, the guideline committee awarded this in a careful manner. If it's logically feasible, it's preferred that delivery be planned at a hospital where someone like Dr. DeAnda or a team of surgeons are available for emergency aortic repair. And in where I am in St. Louis, if I'm caring for someone 4 or 5 hours away in a rural setting whose aorta is normal in Marfan syndrome, who has a low risk, sometimes it's just not possible or practical for that person to be at our place for delivery. So we work with other sites where we think the risks are going to be low. In other settings, we really ask, come to our site, come to a tertiary center to have your deliveries, because if something would happen, you'd have all the specialists available. So again, when it's feasible, it's advisable to have your delivery at a hospital that is capable of managing an aortic catastrophe. And then during pregnancy, routine imaging is recommended throughout the pregnancy, and the surveillance frequency just depends upon multiple factors. A rough guideline is about once per trimester, and then so many weeks postpartum to see if there's been any significant aortic growth during pregnancy. And in some instances where growth is demonstrated, we do much more frequent imaging throughout pregnancy. So there's individualization of that, but emphasizing the importance of repeated imaging throughout pregnancy. Next slide. Dr. DeAnda, do you want to comment about some of the things we decide about with regard to who to consider for surgery before pregnancy, depending upon their condition?
Right. So, and I'll go through these quickly in lieu of the time right now, but our class 1 recommendations for the pregnant patient with Marfan's or some other aortopathy, if their aorta is less than 4 centimeters, we have recommended that vaginal delivery is, when otherwise appropriate, is recommended. When it's greater than 4.5 centimeters, and you have Marfan's, if you're contemplating pregnancy, we also recommend that the aortic root or ascending be replaced. The aortic root in this case be replaced before pregnancy is proceeded with. We have the gray area, and this is the class 2B recommendation, and that's with patients with Marfan's who have the root measuring between 4 and 4.5. Aortic surgery may be considered before the patient becomes pregnant, especially if there is a rapid growth or there's a family history of aortic dissection or sudden death in the secondary to aortic dissection. But this is a class 2B recommendation, which means it would be reasonable, but not entirely. It would also be reasonable not to do this. Next slide. In this, we have similar recommendations for Loeys-Dietz patients. And that's the recommendation that before pregnancy is considered to intervene on the aorta that's greater than 4 centimeters. And in patients with a bicuspid aortic valve, and this is in the absence of a heritable thoracic aortic disease or Turner syndrome, that it's reasonable before pregnancy to address the root if it's greater than 5 centimeters, greater than or equal than 5 centimeters. Next slide. For the class, I'm going to go through this fairly quickly. These are the class 1 recommendations for type A aortic dissections, and I've included them in this presentation. These are very similar to the 2010 recommendations with some expansion. And it's the first couple are very common sense. And patients who are presenting and they have a suspected or confirmed aortic acute type A dissection, that it is recommended that immediate surgical intervention be performed because of the high risk of life-threatening complications. In patients presenting with evidence of renal, mesenteric, or lower extremity malperfusion, it is also recommended at class 1 level to proceed with operative repair of the ascending aorta, as deal with the type A first. And then finally, in patients with an acute type A dissection that partially involves the aortic root, but the aortic valve leaflets are not diseased, then we recommend to leave the valve, resuspend the commissures of the aortic valve, and this is preferable over valve replacement. Each of these decisions, of course, would be can be altered based on the surgeon's experience or what they see in the operating room, but these are our class 1 recommendations. Next slide. The class 2A recommendation is in those patients presenting with an acute type A aortic dissection with clinically significant mesenteric malperfusion. Their celiac artery, their SMA, these are branches that are feeding the gut, if you will, the liver and the belly, the colon, the small bowel. Then the choice is either immediate operative repair of the ascending aorta or immediate revascularization or getting blood to your bowels via either an endovascular or open surgical approach. And this will be based on the expertise of the surgeon, expertise at the center, and as well as the patient. Normally, endovascular approaches are not necessarily performed on patients with connective tissue disorders. However, in life-threatening situations, it is reasonable to use this as one of your approaches. Next slide. And this is a table out of the document, which sort of shows the decision making for those patients with either a type A or a type B aortic dissection, including those with malperfusion or ischemia. And I won't go through this very detailed chart here. Next slide. Some of the reasons why this became a class 1 recommendation in terms of malperfusion. This is a paper that came out of the University of Michigan, and they note that if you have mesenteric malperfusion or a problem with blood flow to your gut, this is associated with a very high mortality rate, and that some centers have begun looking at other ways of getting blood to your bowels before your ascending aorta is addressed. However, there is very limited data on this. If you click it one more time, and this is out of the paper from University of Michigan that looked at their experience in dealing with the mesenteric ischemia first. Very limited data. And they had mixed results, although they did feel that they had decent enough results to proceed. However, there were some patients that fell out during this time period. So type A aortic dissections, I think, as most of the group on this call are aware of, is the deadliest thing that we have to deal with, and it catches a lot of people's attentions, obviously, to try to get the best possible outcome. Next slide. And finally, there's class 2A recommendation when it comes to type A aortic dissections, and this did come from a lot of discussion, and that's in patients who are presenting with an acute type A aortic dissection who are stable enough to transfer. It is recommended that the patient get transferred from a low to a high volume aortic center to improve their survival. And I have received a lot of calls and social media questions about this recommendation, only because this appears to be almost self-serving, that if they are stable enough for transfer, then these high volume aortic centers are getting the stable patients, and the outlying low volume hospitals are having to deal with the train wrecks. But this is our class 2A recommendation, that if you can transfer to a high volume aortic center, it's reasonable to do that. Next slide. And then finally, and these were some of the biggest talking points that we added on to the recommendations for type A dissections. When there is destruction, extensive destruction of the aortic root, or the patient has a root aneurysm or a known genetic aortic disorder, such as Marfan's, then it is recommended that the aortic root be replaced with either a mechanical or a biological valve conduit. In patients with acute aortic dissections, we also recommended that what's called an open distal anastomosis be performed. This does require the technique of circulatory arrest, and that means that we have to cool you like a popsicle and cool you down so that we can interrupt blood flow for a short period of time to your head. And then the last recommendation is when there is a tear in the arch with a type A aortic dissection, or if the arch has a significant size discrepancy, a procedure called the hemiarch is recommended. I should say when there's no tear in the arch, the procedure called hemiarch is recommended, and that's where a portion of the arch is replaced at the time of dealing with the more proximal aorta. Next slide. And then finally, some patients will have an aortic arch aneurysm, and they may have symptoms that are attributed to the aneurysm. As long as they are low or immediate operative risk, open surgical replacement is recommended. There is some consideration, and plenty of people are publishing on this on their own experience dealing with the arch with an endovascular approach, but it is a class 1 recommendation that when it can be done, an open surgical replacement is recommended. Next slide. And for other patients who, if you're undergoing open surgical replacement of your aortic arch and the disease extends into your descending aorta, then a procedure called an elephant trunk procedure can be considered. And And the last one is in those patients, as I noted, who meet the criteria for intervention, but are high risk for an open surgical repair. A hybrid or intravascular approach may be reasonable. Next slide.
Maya?
Another section of the paper was talking about quality of life, both in the importance of regular mild to moderate physical activity. And if you're not sure what that is, Dr. Braverman did a webinar a few weeks ago, and that I think is available on the Foundation's YouTube channel. They also have physical activity guidelines on their website. But the takeaway is that it's important to stay active. There's a recommendation for cardiac rehab after aortic surgery, and this is something that's new. Cardiac rehab had been used for heart attacks before, but research is showing that it's effective for aortic surgery as well. So that's something to ask about, see if your insurance will cover. And then the importance of recognizing and addressing anxiety, depression, and PTSD following surgery. So if you're noticing these signs in yourself, it's worth it to bring it up to your physician. And then hopefully physicians will be screening and looking for these signs, because it's not uncommon after surgery to have some of these mental health issues come up. Next slide. And then we've talked about multidisciplinary aortic teams multiple times tonight, sometimes called centers of excellence. And, you know, they're important for looking at surgery. So how do you find one? You can look at the Marfan clinic directory. Those are all institutions that have expertise in Marfan, Loeys-Dietz, and VEDS. If you don't see one near you, you can go to marfan.org.ask, and Jan at the Help Center can see if she has any recommendations for somewhere that's close to you. And in general, university-affiliated hospitals are a good bet because they do a lot of research. And why is it important? Because our tissue is not like typical tissue. And so we want to have somebody who has experience, like Dr. DeAnda said, it can be like stitching together wet tissue paper. So you want someone who's done this before and who's seen the variety of complications that could happen afterwards and has experience handling those. So you want to ask surgeons how often they've done this surgery, how often they've operated on somebody with a connective tissue disorder before. That way you'll have the best chance for the best outcomes. I know, like personally, recently I had a coronary artery dissection and ended up at a local hospital where I got good care, but they hadn't seen many dissections like mine. And so the information that I got about follow-up was not the same as when I was able to talk with some experts after I got home and get information on the latest research and on just other information about what I should be doing to stay healthy. There are some barriers, which I think we need to recognize. Distance can be a barrier, and so can finances. I think that it's worth it to reach out to hospitals that you're interested in doing surgery with and talk to their social workers, see if there's anything that can be worked out. Maybe they're able to help you negotiate with your insurance company for coverage. Maybe there are options to help with the finances. Certainly, if you're looking for surgery for a child, there's like Ronald McDonald House to help stay at to cut down on costs and things like that. So you won't know until you ask those questions, but it's worth it to ask the questions.
Thank you, Maya. That was awesome. Really appreciate your bringing those important comments forward, and also all your leadership in the committee. It was invaluable. And Abe, thank you for your great. We put you on the hot spot with surgical thresholds in all those cases, and like you always do, you answered them with a lot of thoughtfulness and foresight. So thank you for that. We've been on the call for an hour, and a lot of people have written questions. People are, if you want to stay online for a few more minutes, I think if Maya and Abe are able to stay on for just maybe 5-10 minutes. If it's okay, Eileen, I'm happy to moderate. I'll just kind of go through some of the questions and we'll divvy them up. Let's see. Here's a question. When my husband and children go to their cardiology appointments, do they need an MR-CT as well as an echo? So right now they only get an echo. So that really depends on the condition. So for instance, in Marfan syndrome, for instance, so we try to look at the aorta, the root and proximal ascending aorta, the valves in the heart yearly with an echocardiogram. If the rest of the aorta has been seen pretty well on echo and you're a child, then you usually don't have to get a CT or an MRI. If you're older, usually you get at least a one-time CT or MRI to see the entire thoracic aorta, and then maybe periodically over a lifetime to look for downstream disease. In Loeys-Dietz and VEDS, then probably at least every 2 years, imaging from head to pelvis would be necessary in those individuals, as long as it's asymptomatic. One person asked the important question: is there a recommended age cutoff for peripheral aneurysms when considering genetic testing? No, I think one of the most important sentences in the document is there's really no age limit at which we shouldn't consider genetic cause for an aneurysm, because it's always possible. Sometimes in a family, especially when it's non-syndromic, we talked about the syndromic diseases tonight, but many of the non-syndromics will present in the 60s or older with an aortic dissection. And then when we screen family members, we find others with an enlarged aorta. So we really have to think about that for all. An isolated cerebral aneurysm without any other features in any other family members, that might be a little bit different. Abdominal aneurysm associates with cigarette smoking and male sex and over 65 years old, but also can be genetic, but not the genes we're talking about. Let's see. When to start aortic, how old to start aortic screening relative? That's again a shared decision. Again, if somebody's has an aortic event in their 50s or 60s, we'd screen their children, their siblings. If parents are alive, we'd screen them. If somebody has an event in their 40s or 50s and we don't find a gene and they have children that are, teenagers or less, it depends on how old the kids are, and then a shared decision about that. But again, we usually still recommend screening, especially when they're into athletics and things like that, because it can help inform management if somebody else has a larger aorta. Someone asked about sites around the country for access, and there's the Marfan Ask has a good site for that. Someone asked about tortuosity. So that's a good question by Aaron Everett. So arterial tortuosity hasn't been looked at systematically in Marfan syndrome because we don't do widespread imaging of the head and neck in Marfan. So we don't really know. There is some information that it can be quite tortuous. And I think that's an important research topic that should be looked at, because it's possible that could inform our crude decision-making that we use now. Let's see. Is MR or CT the better scan? They're both excellent scans. They both get really wonderful information that's reliable and accurate. So they really have pluses or minuses, again, depending upon other features, but they're interchangeable. Personally, when I'm, so we use both. We try to use more MR in the long term for people who, for whom that's gets accurate measurements. Let's see. Abe, maybe you can answer this if you know. What's typically done with celiac and splenic artery dilations? At what size is typically fixed? How often should they be followed? I'll answer after Abe does, but I want you to take the first go at this.
Yeah, it depends on whether they're isolated or not. We occasionally do see. It's rare. I think it's rare to see for instance, a celiac aneurysm or an SMA aneurysm. We can bypass those if need be surgically. For people with connective tissue disorders, once again, I'm very, very reluctant to stick a catheter in there and put a stent in there, because I don't think it's going to last. I think the tissue is going to continue to grow. But if you have an isolated aneurysm like that, that can be bypassed. The cutoffs are going to depend on the vessel. And I think for a celiac, for instance, I think greater than 5 millimeters, I would start eyeballing it a little bit more than normal. And you're gonna do the surveillance. The celiac, same. Renal arteries, you can let them get a little bit larger than that. But if they become aneurysmal, then you can replace them.
Here's a question. My daughter was diagnosed with Loeys-Dietz, but Dad and I were tested and don't have it. Should we get an echo to check the aorta? That's an excellent question as well. So if somebody has a genetic aortic condition like Loeys-Dietz, and you know the gene that's involved in your daughter, and both parents were tested and neither have the same gene, then you don't have the condition and you don't have to have any imaging of yourself. If you have other children, they don't have to have any other imaging or gene testing because neither parent has the condition. So that was a spontaneous change in the gene that led to Loeys-Dietz in the daughter. So anybody else in the family would have the same risk as a person in a different family. So that's the importance of genetic testing, to look if you have the gene, then you image and follow. If you don't have the gene and the gene's known in the family, you have to screen other family members. Let's see. What percentage of Marfan patients will experience an aortic dissection or require surgery? The majority will have a surgery, but not an aortic dissection. Our goal is to prevent aortic dissection by recognition of the condition and then timely surgery at an aortic threshold that's a shared decision, generally about 5 centimeters. About 10% of people with Marfan syndrome will have descending aortic disease, and that can be an aortic dissection. And unfortunately, we don't have any good markers as to why that occurs. It's typically not in the setting of enlargement of the aorta. There's a lot of questions about pair surgery. Abe, are you comfortable talking about the pairs?
Well, yeah, I mean, pairs is being currently used in Europe, and I believe it's under trial in the United States. It's not right, ready for prime time. And for the people in the audience who don't know, pairs is you're essentially surrounding the roots and the ascending with a material to keep it from enlarging. I'm not sure if it's ready for prime time yet. I know it is used in Europe, but right now.
I heard a very interesting discussion by Duke Cameron on our board, friend of yours, Abe, contemporary of yours, and you're right. So it's not available in the U.S. It hasn't. I'm not aware of a trial yet in the U.S. It's certainly available in Europe, and I'm very interested in it because it does seem like it does help a lot of people there. The differences are, as Dr. DeAnda said, is the aorta is not replaced. It's encompassed by a graft that's unique for the patient. It fits them. It does require, opening the chest to get to the heart, but you don't have to stop or arrest the heart necessarily. You just go around the coronary buttons and things like that. And so far in Europe, in the centers that are doing it, the aorta is a lot smaller, averaging 4.5 or less centimeters. So again, it's a smaller size aorta, and the outcomes have been pretty good. They, very few mortality, and the early mortality from a coronary complication, but really intermediate follow-up looks pretty good. So I think we don't know yet is the right answer. It's currently just not available here. Eileen, are you seeing any other major themes that we're missing?
No, I think you guys have done a really awesome job. You guys generally, the two doctors and Maya, have done a great job in answering a lot of these questions and grouping them together and really giving some great information. The discussion tonight was really outstanding with all your insights about the guidelines that are put out there. And the gray areas I think are really important for people to know and to discuss with their providers. And so thank you all for a really, really wonderful night. It's really been informative. And so people can keep asking questions. You can do that through our help center. There's Jan Lynch, and there is the website that we've been talking about all night, marfan.org/ask. If Jan is not able to answer it, she'll go to Dr. Braverman, Dr. DeAnda, anybody else on our professional advisory board to get your questions answered. I want to let you all know, anything else you want to add to that, Alan, Abe, Maya?
No, we appreciate the great attendance. It's a pleasure to be here, and we're happy to serve and delight. Thanks for attending.
Yeah, great. Thank you. And thanks to everybody for hanging out with us this long. We have more webinars coming up into 2023, focusing on research this year. That focus continues. Hal Dietz will be with us in February to talk about the latest in genetics research. Enid Neptune from Hopkins will be talking about the lung research. And then we have Jefferson Doyle from Johns Hopkins and Dr. Vanderveen from Boston Children's talking about research going on in the eyes of Marfan syndrome. So those are coming up in the coming year. I do encourage you all to follow us, just actually subscribe to us on our YouTube channel. This webinar tonight will be uploaded there probably tonight or tomorrow. And you can refer back to all the other webinars that we've had in the past and get that other information and these upcoming webinars too. If you do register for the webinar, we're going to send you the link directly, but you can also check out the YouTube channel and see all the content that's there.
You want to drop the link in the chat?
I would, but I might screw up the PowerPoint, so I will not do that. You
Okay.
can if you'd like to. You can also meet a lot of our wonderful doctors and of course connect with community at our walks that are still coming up this year. We've already visited Dr. Braverman in St. Louis. We'll be in Houston in March, where hopefully you'll meet Dr. DeAnda. I'll be in Tampa this weekend. And so we have a lot of walks coming up. If you are not in one of the walk cities, participate in the global walk and you'll have a great opportunity to meet people online and then continue those connections as we all do virtually these days. So lots of opportunities to get together and meet people who are going through the same thing that you are. So I want to thank you all for being here tonight. We had a great turnout. It was really, really important information and hope that this will help you live better. And we are here for you. So have a great night. Thank you, everybody.
Thank you.
Thank you. Have a good night, everybody.
Happy holidays. Thanks for arranging it.
Thank you.